Welcome to The Appetite, a podcast brought to you by Opal Food and Body Wisdom, an eating disorder treatment clinic in Seattle, Washington. I'm Julie Church, the host for today. I am one of Opal's co-founders and a dietitian and nutrition director. And today's guest is Naomi Busch, who is a local physician. She is an eating disorder doctor that's turned menopause doctor. And Naomi has been in our careers, we've kind of been parallel in our work in serving individuals with eating disorders in the local area. And I've always admired Naomi's pursuit of information and kind of being able to give the best care she can to her patients. And I have seen this to be true in how she's now created this menopause practice at Seattle Menopause Medicine. Yes, I'm excited about our conversation today. And one warning I want to give to our listeners, Naomi and I both talk really fast. So you may want to slow down the speed at which you are listening to this podcast if you are wanting to listen to it at a normal speed. But all power to you if you want to make it faster. But we are fast talkers, so buckle up and you are going to learn a lot from Naomi today. Naomi and I's path began in our careers, obviously finding each other in the eating disorder world. And as you can see, this podcast is about menopause, and we're going to get there. But Naomi, can you share a little bit of your journey to this place and, where our paths crossed?
Yeah. So currently I am working and own a Seattle Menopause Medicine, and I had a very circuitous route to get here. So firstly, I was working in family medicine. I started in community health, and then I moved to Seattle. And when I came here, I realized it was really difficult to both be a mom and a doctor at the same time. And so I found a practice, and I was lucky enough to take over a practice and then design a family medicine practice that worked for me. Also then incorporated multiple other women into my practice. And eventually other people like eating disorder companies started coming to me to ask me for help. And that is where I met you.
Mm-hmm.
So,
yes.
yeah.
Yes, in the Seattle area, and this is nationally, right? There are so few physicians, doctors, medical practitioners that have specialized in eating disorder care, so we were always very grateful to have you and your work and your expertise in our community, for sure.
Right. So owning my own practice allowed me to design the practice that I wanted to do, and it turned out that what I was really good at doing was fixing problems rather than actually, they could be medical problems, but they could also be just administrative problems or whatever. And so when eating disorder companies came to me and said, hey, can you see our patients? And I had no knowledge of eating disorders. And then they told me their problem, which is that no one would help them. I thought, okay, well, that's not fair. So let me go learn everything there is to know about eating disorders. And thus became probably a year-long journey to learn everything I could about the medical management of eating disorders. And then I started doing consulting work with them. And so for 10 years, I ran a private practice and also did eating disorder consult, and also just provided, I think, just like friendship, and like community to people around the eating disorder world in Seattle and beyond. And then eventually I got tired. And so that was a lot of work. And so I gave my practice to a friend of mine who actually was also interested in eating disorders. And so she took over the whole shebang, and I kind of took a break. And during that time, I got old, and my friends got older, and they started asking me about menopause, and specifically my book group started asking me about menopause as I was like the resident doctor in the book group. And I realized I knew nothing about menopause. And just like eating disorder work, I decided, well, that's not fair. There should be some place for my friends to go. And so I learned everything I could in probably, quicker. I wasn't working at the time as much. So I learned everything I could in like 4 to 6 months, got my menopause certification, and then decided to open up my clinic when I realized there was nowhere to send my friends, which meant there was really nowhere for other people to go as well. And so I also decided when I looked out into the menopause world that it was really interesting because there was this huge intersection, right, between weight inclusivity, health at every size, eating disorder, body image, and menopause. And so I felt really compelled, to open up my clinic and to do the work I do.
Yes. And I do feel as if it's being talked about a ton. I'm sure it is because of my age, the algorithms on Instagram.
Yeah, exactly.
Who's getting advertised to. But it is true, right, that in the last 20 years, there was a kind of a gap and a silence. Do you want to speak to why maybe we weren't hearing about menopause much in the last?
I mean,
Is it because I was too young to hear about it?
No, I think, it's interesting. I look back. I've been a doctor for 25 years, which is kind of nuts. Anyway, and I've been a doctor for a long time, and I don't remember ever really thinking or hearing about menopause. Like, there wasn't any reason not to. It was just, if you want to ask me my personal opinion, which isn't evidence-based,
Sure.
yeah, it's because, when as women get older, we become invisible. And I think we all, anyone over the age of 40, I would say, which I don't consider very old.
Yeah, I know. I don't either.
Like, you start to feel it. You start to feel a little invisible. And so I think in medicine, the same thing happens, where there's a lot of research done on men. And I can tell you why that is, because, and not just, gender discrimination, it's also because women can get pregnant. Right. And so when they do these, when they do research, they don't want women to be pregnant or at risk of being pregnant. And so they were excluding them from research for that reason. That is a big reason why. And so, we didn't talk about women over 50 having heart attacks or strokes or what should we do about them. We just sort of lumped them in with men. And it was really weird. It was like we kind of just ignored the whole menopause transition entirely. I mean, that's kind of crazy.
Yes.
But anyway, so, and I think that there was also, and there's a lot of press around this now, is that in 2002, the Women's Health Initiative, which is the really very large randomized clinical trial that was being done, was halted and announced by the New York Times rather than, the medical community, that hormone therapy would increase your risk of breast cancer and chance of having a heart attack. And so it was halted, and then no one spoke of menopause again.
Yeah. That's the thing that I was very aware of. All the other deeper thoughts about that are really good to hear as well, but I was very aware of that. I mean, I remember that kind of in my own journey with older women in my life, too, of kind of that tension of their conversation around that. And then also I think how often is this talked about intergenerationally and in families and all of that? And I have very, very little moments in my life of hearing from the older women in my life about it. So, yeah. But I'm glad that we're talking about it now and that it's getting more common, I guess. And there's more folks like you that are going out and actually opening practices and making themselves very clearly an expert in it, so that I think then it just increases awareness. I think in the same way we've seen it with eating disorders, right? It's just it increases people's possibilities to get the help or to consider that maybe they're not alone or that this maybe isn't normal or that this could be changed, right? So
Right.
I think it's great.
I think what we've seen, and especially probably in the last 3 years, and I don't know exactly why it changed, like what happened in the last 3 years that like people were like, menopause. But I know is that so. I mean, and maybe it's just the bloom of social media, right? And the bloom of podcasts, like this, right, where people are talking about different subjects. And so, I mean, I can think about like the few podcasts that were out, and then how many there are now, and also with like social media bringing awareness, both positive and negative, to menopause and midlife women. I also tell my patients, I think too, and I think about this sometimes, is that I kind of believe it's a function of where we are as a society, and that every year more women become CEOs. Like there's a tiny percentage of women who run companies, right? But every year more people reach that glass ceiling, right? Like I should say break through their glass ceiling.
Okay, nice.
Right? And like every year that happens, and those women are hitting menopause. And when that happens and they start getting brain fog, when they stop being able to sleep, when they start having hot flashes while they're giving important lectures or talking to Congress or at the UN, they're like, what is happening to me? There's got to be a treatment for this. And I think it's those women who actually kind of started seeking help. I believe this to be true, but that's my opinion, and that they actually have paved the way, because there were TED Talks about it. If you look back, there's women in their 70s talking about sort of menopause revolution and freeing themselves of the burden of caring what people think about way before the social media trend. And so that's what I think.
Yeah.
And that's what I see in my practice, is that people come to me and tell me that. Like, I don't know, like let's make it up. Like, I lead company X. I'm in a room of 300 people and I'm giving a lecture, and all of a sudden my mind goes blank and I do not know what the next sentence I'm about to say is, and that might happen on this podcast to me. But I'm just warning you. I know. So like, and you can imagine I've had people come to me and tell me they're going to quit their jobs, and these are women who are doing amazing things, and I'm like, whoa, wait a sec, don't do that yet. Let's see if we can make you feel better. I mean, I put people on FMLA. Like I will give them, leave, up to 12 weeks to get their hormones started, to get their anxiety under control, never having to use, SSRIs maybe, but like really just being like, you are in the menopause transition and it's significantly affecting you.
Yeah.
And I mean, I've brought people back to work. It's kind of amazing. Like it's such a simple solution in a way. And it's so hard to believe that these women have sought care from multiple other doctors before getting to me. And anyway, it's really, I mean, I know it's a little different than what we're here to talk about, but it is like, that's like where like my passion comes from, right? Is like seeing the effect and like thinking, no, like me too, right? Like me too. I am a 50-year-old woman and I'm in the top of my game, right? I'm super smart. I have my own practice and I run my family and I go on vacation and I have to be able to function and do all that stuff.
Well, so my mind is going in so many different directions, but I do want to highlight that next week I am recording a podcast with a local researcher who has done their dissertation on that exact thing, is women, workplace, and the menopause. So I'm going to be creating or kind of sharing about the research and interviewing that researcher next week. So as a part of this series, they'll get to talk about that. So that is very relevant, and it is not just the biological impact of menopause, but it is psychosocial impact of menopause.
100%.
So can you do a quick overview of sort of what is menopause? And I guess I want to caveat this to say that we've already talked a lot about women, used that phrase, and this is going to be a fairly gendered conversation. Can you speak to how this can be as inclusive as possible in our conversation and allow for our listeners of all different genders to be able to take in this information?
Yeah, I think that we use the word women, but I wish we had a different word for it, but what we're trying to say is anyone who's born with a uterus. Obviously, anyone with a uterus and ovaries will go through, I shouldn't say uterus, I should really say ovaries, will go through the menopause transition.
Sure.
Right? And so anyone, and whether you're non-binary, trans, you will, if you have had or have ovaries, like you will go through the menopause transition. And it's really important to include everybody. And when we talk about it, it's easier to say women, and that's unfair.
Yeah. Okay. So thank you for mentioning that. So when we talk about menopause, what is happening biologically that we then term as peri-menopause and menopause and the transition, quote unquote, I'm using air quotes, that you've already been using that phrase. Right. So please,
Yeah. So I think that we could all agree that perimenopause is elusive at best, and that there is a medical definition of perimenopause and the menopause transition. So there is something called the STRAS guideline, which is, I think it stands for the stages of age of women, something like that, reproductive health. But it was designed many years ago, like over a decade ago, and when you look at the STRA guideline, and that is how we actually, figure out what is perimenopause or menopause, the only thing that really can delineate it is your cycle length. And the problem with that is that not everyone has a change in their cycle length prior to just no more periods. Okay. Right? So what the STRA guideline tells us is that, which is, again, reproductive health, is that somewhere around 7 years, let's pretend, before your last period, you might notice a change in your period, the cycle length, the time between periods, of more than 7 days. And that is the definition of early perimenopause, a change in your cycle length by 7 or more days. And that can last for as long as it wants to last. And then late perimenopause is a change in your cycle length by more than 60 days. So usually a lengthening of. Whereas like early perimenopause, a lot of people will tell me they have like more than 2 periods, like they'll have 2 periods in a month. So their cycles are like 18 days, right? And now you're talking like cycles are 60 days or in late perimenopause. And if that happens to somebody, I can tell them, research shows that menopause will be in about 1 to 3 years.
And wait, can you just, what is menopause then?
Yeah, so then menopause is just when you stop having your period and
Yes.
everything beyond.
Okay. I think
That's
it's
it.
interesting when
Right.
I dove into all the definitions as it mattered to me more. I was like, oh, that's all that menopause is.
Yeah,
It's just
menopause
like
is
no period.
no
Oh,
period.
Okay.
And it's for the rest
simple.
of your life. Like people say like, well, my menopause was, X day, but you're like, well, actually we're all
Always.
every
Yeah.
woman who no longer has their period is now in menopause. Whether it's because of surgical reasons, whether it's because of just general age reasons, or chemotherapy, or any reason you've stopped having your period permanently, we consider that menopause. And then the menopause transition is actually longer than menopause. Okay, so like that day of menopause, I should say, the day of your last period, the menopause transition actually goes from early perimenopause. When you enter into the menopause transition, you're going to go through menopause eventually, all the way up to like 3 to 5 years post menopause, that date. And so that's like the length of your symptoms. And that's why that's important, is because you can imagine you can start having symptoms 7 to 10 years before your last period, and you can have symptoms all the way, to the average is 3 to 10 years. Some people have symptoms of menopause for the rest of their life. I think studies have shown, and of course these studies only go to 79 or 80, okay? But they still show that up to 79 or 80-year-old women, 15% of them still have menopausal symptoms, including hot flashes that are disruptive to their life at that point. So it doesn't. So some people will have an easy transition, is what I like to say. Like they have 0 symptoms. So yeah, 15% of people never have any menopausal symptoms. Okay, so that means like the majority of people, that 70% that's left over, have symptoms that go for those years and then taper off. So if you never did anything about your symptoms, about 5 to 7 years after menopause, you would feel better.
Okay. Wow. What's so interesting is that's a large part of a person's life then. It could be 20 years of somebody's life. If you're saying 7 to 10 before the menopause, the
And
last
then
day of the
7
period,
years after.
and then, that's almost 20 years. It's just a large chunk of somebody's life. Okay, so what are some of the common concerns? Like what are some of the symptoms or the things that people then are finding distress in?
Yeah, so it's interesting. So again, like I mean, coming back to the straw criteria, the reason why I and many people, like leaders in the field, are like, we need to revisit this idea, is because you can't just use the period as, or menstruation as a notification of perimenopause. Because what people are actually coming to see me with are very normal cycles. And now they have sleep disruption. They're waking up at 2 or 3 in the morning. I mean, everyone's first symptom is different. Like, we have no protocol or predictability of what someone's going to go through. I like to describe menopause as it's like a box of Legos without instructions, right? That everyone's going to build a house and they're going to look a little different. But like, you don't really know. But everyone has that box of Legos, and it's all possible. And we know you're going to build a house, and it's going to be whatever kind of house you're going to build. So you could have sleep disruption is a big one, where you wake up. Usually sleep initiation is maintained, meaning like you can fall asleep, but now you're waking up at 2 in the morning, 3 in the morning, which I also like to joke about, because if you read Stephen King, which I do, like there's this thing, the witching hour, 3 in the morning. And I'm like, oh, maybe you got that from menopausal women.
Totally.
They always wake up at 3 in the morning. Anyway, and then and there's a good one to talk about with that is, what could be causing that? Some people wake up just anxious, like existential anxiety is what I call it. Okay. There's nothing wrong. This is what they tell me. There's nothing wrong, nothing new. They just feel anxious. And it's like that book where there's that bird running around and the sky is falling, and they just wake up and they're like, the sky is falling. But they're like, nothing changed. And they can recognize the difference. Same thing with depression. Like they'll just wake up and feel existential dread, right? And this is not normal. It's not even normal depression. It just comes on kind of suddenly. And then hot flashes, of course, can start at any time. Some people start having hot flashes in their 30s, and it doesn't mean they're about to go through menopause. Like I just said, it could just be the first symptom. And hot flashes, just so you know, like are defined typically as heat building from the chest up to the face. And they can be like really mild, like you just feel warmer than usual. You don't have to put on a sweater like you used to. They could cause you to feel actual heat and sweating, but you don't have to take off your clothes. And then, of course, they could be severe, where like you literally feel like you're about to pass out because you're so hot. And they only last maybe 30 seconds. Sometimes they last for minutes, and then they go away, and then you have chills. So that happens. Some people get pretty extreme brain fog, which is, of course, defined by the user. But we, when they do research in the brain, what we really see is that there's verbal processing, very difficult to verbally process, meaning you learn something, you hear something, but then you can't remember it, and so there's some like decrease in verbal processing, spatial memory. So you no longer remember where you put something. And the problem with that, the problem with that is that your loved ones don't realize this is happening. And so they're still relying on you to be the ultimate finder of things. And that doesn't happen, right? Like, I can't tell you how many times my husband has said to me, hey, do you remember where I put my keys? We finally had to have a conversation in a calm moment where I was like, listen, honey, I no longer remember where you put stuff. I no longer remember where I put stuff. So from now on, you can't ask me, because every time you ask me, it reminds me I don't remember. So that's really frustrating and upsetting to me. So we have a rule. When you take something out of a place, you put it back into the place, right? Like,
that's helpful.
There's places. But anyway, and then of course, multitasking gets affected, and then concentration and focus. And so women come to me all the time and think they have adult onset ADHD, and I'm like, no, you might be perimenopausal. And those, you can see like those are also really great strengths that women, and I'm gendering everybody now too and making huge stereotypes, but that those are like strengths of women. And so these were things that we did without ever thinking about them or appreciating them. And then all of a sudden they're gone. And I feel like the worst part of brain fog is actually this moment where you're speaking and you don't know where you're going. Or like the word that you cannot remember and it's on the tip of your tongue and you remember everything else but it. Anyway, and those are I would say like the biggest ones. And then of course there's like some of the physical symptoms. People start getting joint pains. They can get things like frozen shoulder in your 50s. There's some link with menopause there and estrogen, deficiency. People start noticing a change in their blood pressure. Like these are all the things that estrogen has a beneficial role in. So their blood pressures might go up. Their cholesterol might get bad. They might have elevated, this is kind of where we come in, right? Like their metabolism changes. And so that's a lead in. The metabolism changes and they notice maybe their doctor is now telling them that they have too much sugar around and they have something called a hemoglobin A1C that's elevated and they might start looking like they're pre-diabetic. And all these things are happening, 10 years maybe before you are going to go have your last period.
Mm-hmm.
Yeah. Sorry.
You didn't mention any sexual dysfunction, but I feel like that is something that some definitely would be talked about or not.
I think that, so sexual dysfunction is interesting and like, we could have a whole podcast on that because I kind of love talking about sex. But actually, so vaginal, so there is, with estrogen deficiency, people, and that can happen in very early on, is people can get vaginal dryness and vulvar dryness. And so sex can become painful. But there's also, I think, what people are noticing is this decrease in libido that can happen. And that is what I would say multifactorial, right?
If you're having all of those other symptoms that we just talked about for 5 minutes, I wonder.
So I kind of say like, well, and then they've done studies on it where they look at people in new partnerships or new relationships and they're like, it doesn't seem to be as, prevalent, the lack of libido. And you're like, right, because they don't have all the years build up to that point. And, but there truly is a vaginal dryness and things like that can happen.
Thank you. Okay. So that's a lot. I think the one other thing that you haven't said specifically, but I just want to clarify for people that might be at the very beginning journey of learning, the lowering of estrogen. That is one of the main tests that actually can be looked at, right? I mean, one of the things that then is being measured, it's also related to what might be some of the treatments that you would recommend, right? I think that for someone that isn't even like, okay, these are all happening. Why are all these things happening? Well, because hormones are changing, right? So I don't know if you want to specify that or say that in a more technical medical way, but estrogen, testosterone.
Yeah, I think that's a really good point because if, one of the reasons I am very passionate about this field is also to kind of a promoter of evidence-based medicine, right? So during perimenopause, it's very, very difficult to check labs that are accurate. And people will sell you this idea that they can check your labs or do fancy tests, which we won't name because I don't want to get in trouble, but that costs thousands of dollars and do not tell you anything more than what I just told you, which is that this can happen to you, and until you have your last period, right? Or let's say you have, or people might say right now, they might be thinking, but I don't have a uterus, so I don't know. Or I have an IUD, and so I don't have my periods. Like, how will I know? Or I'm on continuous birth control pills. Like, how will I know? Is it important to know? And I'm like, it's not really important to know. What's important is how you feel. So if somebody comes to me and they want their labs checked, or I think there's reasons why I will check their labs, and I'll tell you. So if they're under 40, it's not normal to go through menopause. I should have said that. Like the age of menopause, which is deemed natural, is if just to naturally go through menopause is between the ages of 45 and 55. There can be later menopause. There's nothing wrong with that actually, but earlier menopause has repercussions. And so if you're anything under 45 is considered early menopause, under 40 is considered premature ovarian insufficiency, which is really important. So I check labs if they're under 45, and yes, I check estrogen levels. I check and I check a sensitive estradiol. I check follicle stimulating hormone, which is your brain telling your ovaries to make estrogen. I like to say the higher it is, it's like someone's knocking at the door, but no one's answering. Right? So it's your FSH will go up and up if there is no estradiol being made by your ovaries. Okay. And so the higher it is, the more we think, okay, this person is close to menopause or in menopause. And one reading of any of these things does not make a rule. Right?
Sure.
Yeah.
Sure.
And then testosterone levels, we check testosterone, and I usually check total testosterone, and I check a sensitive testosterone. And we will check that if someone's having symptoms of low libido or sexual dysfunction, female arousal disorder, things like that, to see if testosterone therapy is viable, meaning, that if your testosterone is high, giving more isn't going to help.
Okay.
Right. So I do check those 4. I mean, and then, that's those are the basics.
And I really appreciate the naming of some of the ways that there's capitalism integrated into.
It's totally.
And be careful.
I want to say that too. I mean, just be careful because, women want to feel better. And there is a lot of people who will sell you things, and checking labs every 3 months is not necessary. Checking when you're missing your period is helpful. That is very helpful information. But if you're regularly menstruating every cycle, we're going to find pretty normal labs. Mm-hmm.
Great. So as I hear all of this, my brain, and because my career has been all in the field of eating disorders, of course, I've just been feeling and noticing all of the parallels with individuals that have struggled with an eating disorder or are currently struggling with an eating disorder, and then also layering on perimenopause, menopause, and all of these symptoms. What do you want the listeners to know about that? I mean, I just, the metabolic issues that you mentioned, like changes in metabolism and things like that, that can be, for many, lead to weight changes, right? And body changes, body composition changes, as well as actual maybe number on the scale changes, right? So I'm curious what you would say about that and kind of just what your reflections are, because you've worked with so many people for years in the eating disorder field and been in those hard, difficult moments with them. And then now here you are in the hard, difficult moments with individuals in this season of life that is a biological change that will happen to all. Yeah. When an eating disorder is something that, isn't going to happen to all. So I guess, I'm curious what your first things are that you want to talk about or share or.
Yeah, I mean, again, going back to, capitalism, right now we are inundated with weight management and the idea that we need to manage our body size for health. And that has, been called out time and time again. You can't really turn on the news or turn on your Instagram just to look at people's pictures without seeing something or hearing something. I mean, the football ads,
Yes.
like I was so upset during, like, with those Super Bowl ads with the GLP-1s. I mean, it's very intense, is what I would say. And the menopause world is not immune. If anything, it's sort of, again, like the next money grab. And because you can imagine when you put people on weight loss management, they're going to have to come back and see you over and over again for the rest of their life. And so there's that. Okay, so that my cynicism aside.
Okay,
My cynicism aside. But thinking about just the way that women's
Yes.
bodies change during the menopause transition, right, which we
Yes.
now know is a long time, is that, so I guess we should start with, we know from just studies like SWAN, which is the study of women across the nation, which has been an ongoing study, which is over a decade, and it's pretty cool. I mean, they just watch people age, and they do lots of side projects, and women are agreeable to this, and it's been really eye-opening. So what we know is that women, and I would say all people, including men, we know, gain weight throughout their life. But the difference, I think, and a lot of this is my opinion, okay, we'll caveat with that, is that women, unlike men, are told that they cannot gain weight throughout their life. It is unacceptable, right, for a woman to be a different weight at 20, 30, 40, and 50. She must be the same weight, right? And I know you're nodding your head. Like, it's so frustrating, and it's so true. And what Swan showed us, though, is that women gain, a few pounds every year, which makes sense to you and me, because a 20-year-old body is not a 40-year-old body, and it would be normal for someone to be 10 pounds heavier at 40, right? If they gained, a couple pounds, a pound or half a pound. But what women do is that they change what their behaviors are or their eating patterns. So they restrict or they exercise more when they get on the scale and they see a change in their weight. And so throughout their life, this is, again, Naomi's theory, is that women have restricted or changed their behaviors and that has worked for them. And I'm, again, air quoting, worked
Sure.
For them to control their weight up until age 40. Let's pretend an average age of 40.
Okay.
And then all of a sudden, they get on the scale one day and they're that 3 to 5 pounds change, like they've always seen every few years, right? But nothing they do will help them anymore. And again, air quoting help, right?
Yes,
With weight management. And they try restriction, but they already have restricted their calories to such a low level. Their body is like, nope, I can't lose. This is my metabolism where it is so low. This isn't going to work. They try increasing their exercise, but now they're in a place where the perimenopausal transition is working against them. And so that looks like, if you have a fluctuation of your estrogen levels and fluctuations of FSH, what we know is that changes the way that our muscles respond to energy. So they don't take in carbohydrates as well as they once did. They really have a hard time using, what we would normally think of as a carb load, before exercise. All of a sudden it's not working, which means so you go and exercise and then you don't gain any muscle. And it's because of this fluctuation of estrogen. And then
I'm thinking about fatigue also.
right,
and
you're
just
also
being
tired.
and
You maybe people have fallen off their paths of like exercise and behaviors and things like this. But even when they go try to get back on that path,
that's what you're saying.
it's like their body doesn't respond like it once did, and so they get very upset.
Yeah.
And then again, looking genetically at people, people's bodies change, right? And so up until now, they might have been able to control it. And now it's like it's doing what it wants regardless. And so therein lies like GLP-1s, right?
Yeah.
So now come in the weight loss industry to say to women, oh, there's something wrong with your
this.
body. Use this to fix it. And rather than saying like, okay, like let's redefine what is normal and what is, again, just bringing up what I said at the very beginning, you feel invisible. And so here you are, your body's changing. You already feel invisible. So like, what is beautiful? Like, what is attractive? And so it's just really
and what feels good.
What feels good.
And
it's hard. It's
Yeah.
really, really hard.
Yeah. And I appreciated on your website too, how you mentioned kind of how you approach from a weight inclusive lens, saying that you take a weight inclusive approach. focusing on symptoms, concerns, and diagnosis rather than size. And so I can imagine there are lots of people, and I would strongly encourage somebody who has struggled with an eating disorder when they are in this transition to seek out help that is weight inclusive, because otherwise, yes, you are going to be inundated with the same messages that you were given. And you need to have a strong advocate, a strong caregiver, a strong provider that is going to be there for you to say, wait, do not let weight be the focus. Again, remember where that took you when you developed an eating disorder. How about we don't focus on that again? Like, we've got to keep you away from that focus. So I really appreciate that you're doing that and you're bringing evidence-based research care to people and keeping them away from the focus on weight. And I understand many people probably are still seeking you because they're concerned around that weight change resistance that they're experiencing. And I'm so thankful that you're somebody that can at least give them a voice in opposition to everything else they're hearing. And perhaps in the same way I think of people when they're actually nourishing themselves at the beginning and early part of eating disorder treatment, when they start to go, oh, wow, like my brain is working again. And, oh, I'm feeling energized and I feel like myself and I want to love others and I have love for myself again. I could see how you might have some of that same experience when somebody might be coming to you in all of this fog and difficulty and symptoms and everything. And then they are treated by you with this compassionate approach and they go, okay, like I still maybe am having a hard time adjusting to how my body looks or how I feel in my body. And wow, I'm actually focused again and I'm sleeping again and I'm feeling more like my body's a little bit more predictable. And so I'm hopeful in that you're out there doing this work for sure. So
yeah, it's really hard. And for me, the struggle is real because people come seeking weight loss.
I bet.
And hormone therapy is not a weight loss therapy. Like and the weight inclusive approach is really, we're going to get you healthy, meaning, we're going to work on your sleep and we're going to work on making sure that you're eating, that you're eating enough.
Food,
gosh, it's so hard. People are not eating enough, and that you're moving your body in whichever way is accessible to you. Right. And if in treating your symptoms. And so if you want hormone therapy, if you want non-hormonal therapy, I don't have a preference. I just want you to feel better. Right. And then once you feel better, then I feel that it's up to, I do believe in body autonomy. And so if people want to change their body, that's up to them. But they need to be in a state of mind where they feel like they can make that decision rationally and not based upon what social media is throwing at them or this feeling of, oh, it's this drug, it's my body. And if I just lose weight, I'll feel better, which is what the message has been for so long. And so I do, I do, with hormone therapy, and I guess the way that people probably want to know, like, well, how does hormone therapy affect your body?
Because that can interrupt it. So that is the main intervention or main treatment that you're giving people, or what would you say?
I would say that, hormone therapy is usually why people seek my care, but then sometimes it's not accessible to them, or meaning they have reasons why they can't take hormone therapy, which we don't need to go into, but there are non-hormonal options, medications too, for treatment of like hot flashes or even sleep disruption. And so I think that's important because you can imagine if people are not sleeping, we know that sleep, and if I could just hang my hat on any one thing, like what is really changing people's bodies, it's probably sleep.
Okay.
You know what I mean? Like
Sure.
the lack of sleep. And I try to do it all. And hormone therapy is a big part of it. 80%, 90% of my patients want hormone therapy. And when you stabilize people's hormones, then the things like their body composition changes can stabilize, right? So that the muscles respond and they can build their lean body mass or hold on to it. There is this theory and there is a little bit of evidence that, during menopause, the menopause transition, people will notice weight gain, in the midsection because it's well documented that people go from having fat around the hips to fat around the belly. Fat around the hips is considered, this is so gendered.
Yes,
gynoid.
I know about what you're about to say.
And then android, and it's so
Yes.
annoying. But the point is that people will literally tell me this, and I'm like, yep, that's normal. And there's many theories about why that is. But when you're on hormone therapy, it just sort of kind of neutralizes it. It doesn't reverse it, and so people might notice like they just feel better in their body. Like, oh, it's not, they're going to the gym and they feel stronger. I mean, it's pretty cool. I mean, that's cool. Or like that they have more energy, right? They're sleeping through the night. And so now when they wake up in the morning, they just feel better. And like it takes the, I want to say it takes the focus off their body a little bit,
Sure.
hopefully.
Great. So I'm mindful that we haven't maybe focused on some of the mental health symptoms, and I'm wondering what you can speak to in that regard, because I find that in my peer group, my own self, that is some of the most impactful, life-interrupting anxiety, depression. So I'm wondering if you can speak to that and if you are treating that through hormone therapy and or psychotropic medication. Yeah. Can you just speak to that a little bit? Because that obviously, for those that have struggled with eating disorders, majority of the people who struggle with eating disorders obviously have co-occurring depression, anxiety, other kinds of disorders. So I just would love for you to speak to that a little bit.
So, I mean, 100%. So that does happen. But I think, so what we know about what we would consider, I like to call perimenopausal anxiety or depression is that, so in this country, the guideline used to be that you started with psychotropic medications like, name brands like Prozac, Zoloft, Lexapro, like those kind of medications, that you would start there. And then if you didn't get better, then you would add hormone therapy, especially if somebody was having hot flashes or other perimenopausal symptoms. In other countries, it's the reverse. So like in other countries, they have recognized, I think the British Menopause Society has recognized that perimenopausal anxiety and depression, and again, air quoting, is a real thing, right? And so that it can be, if somebody has symptoms of perimenopause and also has this anxiety and depression, and it just sort of, it's like at the right timing, then starting with hormone therapy, if that's what they wish to do, can be very effective. Is it always 100% effective? No. And so what I talk to my patients, I figure out which way they want to go, and that's what we do. And a lot of times, I don't make guarantees like this is going to completely reverse all of these symptoms. But I will say, we'll see how it goes. You come back, and if we need to, we can add, we know pretty quickly, actually, like probably within a month, if you need to add something to it. The other thing that I think we didn't talk about, but I'm going to mention now, just to give it some light of day, is the collision between premenstrual, what we call premenstrual dysphoric disorders like PMS and PMDD and perimenopause. So that is like a crash. It's like a terrible accident on I-5 here in Seattle. So basically, if people have symptoms of PMS where they get a little, again, a little crabby before their period, or PMDD where they have sort of a life-changing, disruptive, usually depressive, sometimes anxiety, about 2 weeks prior to their period. And then here comes perimenopause, where periods become inconsistent. They can start having those symptoms all the time, right? And so then those people come to me too in a state of despair, and I usually will offer a version of some kind of hormone therapy, whether that is contraceptives, oral contraceptives or hormone therapy. The difference between those and menopausal hormone therapy is that they control your cycle, and menopausal hormone therapy do not. So a lot of people have given oral contraceptives a bad rap in the menopause world because many, many women feel dismissed when offered contraceptives, like oral contraceptives, instead of menopausal hormone therapy. But there is a place for them, and if they need cycle control, is what I like to say.
I see. You
need to take control of your cycle. If the moods are cyclical, and they get more intense during perimenopause, let's take control.
Yeah.
Or if you're having 2 periods a month, menopausal hormone therapy is not gonna fix that. So let's take control of that, right? And so I have lots of different tools, not very many, but a few different tools, 3 to use. And I think for mental health, it can make a big difference. The other thing with eating disorders or people with pre-existing mental health, previous well-controlled, or maybe they're off their medications now because they came off of them for their previous, depressive episode. Or I would say that, and again, not evidence-based, this is just my experience over the last few years. People really know the difference. if they say this doesn't feel like depression, like this is something, a different kind of depression, and they will tell me that. They'll say, I had a history of depression, or they're already on something, and they're like, this is so different. It's the only word I can use is that existentialism. Like it's just different, and it can be debilitating. Yeah.
Okay. Yeah, and I think when you're talking about the PMS symptoms too, it's like some folks I've understood too have never really had a lot of that. Very simple, basic, pretty routine periods and cycles. And then, the perimenopause season is like, whoa, wait, am I a 14-year-old again and having my first periods and trying to figure this whole thing out again, right? So much more learning. And I think the thing that comes to my mind about it is it does draw us into our body. It's a whole new phase of learning about our bodies, which I think is beautiful and wonderful. And what we do in our eating disorder work is embodiment and trying to encourage people to come and trust their bodies again, or, from in their eating disorder recovery. And still society is not oriented towards that, right? So the drawing away and getting somebody else's answers about our own bodies is really what our society still tells us to do. And so I just think that this is another phase of life or another condition, another situation that leads people, hopefully, to get guidance that your body can be trusted. Listen, your experience is real, and I appreciate that you're doing that. Okay, so what about a few myth busters to close us out here?
So the first thing is, do we all need to take creatine?
Okay, please, let's talk to that.
No. Creatine has been shown. There's some studies that are like athletes, right? So we're talking like, I think one of the studies I read was Michigan, University of Michigan football players. So athletes to help build lean body mass. And so I would say, yes, like if you are working out and that is your goal and you're trying to build lean body mass on the days you work out, this is what I tell my patients, 5 grams of creatine. Do you need to load it? No. There can be problems with that. But, if you, and when do you take it? If you, 30 minutes before you exercise up to 90 minutes after. And it's when you exercise that you need it. So it's not going to build lean body mass. This is the myth. It's not going to build lean body mass without you lifting weights. Okay. The second one is, am I going to get dementia if I don't take hormone therapy? Is something bad going to happen to me? And the answer is no. Many people live to be 90, 95, 100 and never have been on hormone therapy before. So we have other ways of surviving without estradiol. Our body can make other kinds of estrogens. So we're not completely estrogen deficient. It's just that some people have a lot more symptoms than others, and those people can benefit. Another myth would be, do I need to stop my hormone therapy when I turn 60 or 65? A lot of people come to me with that question, and the answer is no. You can take hormone therapy for the rest of your life as long as it's serving a purpose. You should never take any medication or supplement if it's not serving a purpose. And so if you no longer want to take hormone therapy, if you want to take it through your transition, I would say wait 5-7 years after your last period, try coming off of it. And then if you feel fine, great. And if you don't, go back on it. And also bone health, right? That's one of the reasons why you should be on, or you could be on hormone therapy for the rest of your life, is you should, know what your bone health is. And and the last one, which we didn't talk, and so we can just open a can of worms and then finish off and then finish off the podcast, because this is my favorite way to open this can of worms is, does hormone therapy cause breast cancer, right? And I would be remiss if I didn't just give it its 30 seconds. And the answer is, we don't think that estrogen causes breast cancer. The studies on estrogen alone, estradiol, conjugated equine estrogen, are either neutral or show that there is a benefit, like a decreased risk in breast cancer, if you do not have a uterus and you do not need progestogens. Then taking estrogen alone can actually be beneficial. Okay. Now, when you add a progestin in there, what happens? And it's controversial. There's 26 studies. And what I tell my patients is this: progesterone, we have 2 observational studies that show no increased risk. They're observational, which means that the people entered into the study were probably healthier right? Because those people were already on hormone therapy. We didn't give them hormone therapy and then follow them. Okay, so you kind of have to sit with that for a second. But from what we know, it doesn't look like it causes an increased risk of breast cancer. That's your body's identical progesterone, which we usually start with. And then progestins, which are synthetic, they look like progesterone. They act like progesterone, but they're not progesterone. Okay, they're synthetic. Which in this country we have norethindrone and medroxyprogesterone acetate and a couple others. There seems to be a slight increased risk, and that risk is not what in medicine what we consider clinically significant, meaning it's less than 1 in 1,000. And you might think, 1 in 1,000 sounds like a lot. We do a lot of things in medicine that are 1 in 1,000. It's not. We don't really reach clinical significance until it's higher than that. Like 1 in 300 anyway.
Okay.
But when I always will check people's, and if you have a high risk of breast cancer in your family, but you yourself have not had breast cancer, hormone therapy is still available to you. I just say know your risk. And so I calculate out people's risk. And then if we add in a progestin, a synthetic progestin, not progesterone, I would say if your risk is 10%, now it might be 11%. So that kind of like qualifies it. You're like, so my risk really is having been born with ovaries.
Yeah.
That is what gives me my risk of breast cancer. Adding this progestin might increase my own personal risk by maybe 10 or 20%, going from 10% to 11%. And I know there's a lot of numbers, and that's what I say to people. But the answer is it's complicated.
Yeah.
And it's available, like people should have this conversation with their physicians. And if they don't think that what they're hearing is what they have been reading, then they need to find a menopause specialist or somebody else to talk to about it.
Yeah. I hope that's what the listeners have heard. And I hope especially those with eating disorders have heard you need not only the menopause expert, you need somebody that understands eating disorders, is going to be very sensitive to all of this and continue to align with your recovery goals, keep you in recovery, as well as helping you make the best decisions you need to for your own body moving forward in this phase, right? In the transition, menopause transition. So there's so much more we could talk about. Oh my gosh. Okay. Well, we're going to need to finish it up though. Yeah. So thank you. Thank you, Naomi, for being with us, for being on The Appetite, sharing your wisdom with the listeners. Listeners, if you want to learn more about Naomi and the work that she's doing, you can find her at Seattle Menopause Medicine. And I will make sure to link that in our show notes. So please check there for being able to quickly find her. And I want to also thank Jack Straw Cultural Center for sound engineering, Aaron Davidson for The Appetite's original music, and David Bazzi for editing. If you want to learn more about Opal's programming, please visit us at opalfoodandbody.com or follow us on Instagram. Until next time.